Well, there were three fantastic talks from our three distinguished professors, and it's my job now to try and summarize some of the things that they said and perhaps give you a few highlights to take home. Of course, the problem that we're talking about here is contact lens discomfort and the dropouts that they cause as a result. And Lyndon showed us in his data that maybe we're still losing about 25% of our contact lens wearers due to these dropout kind of problems. And I think the information that we've had here helps us to understand a little bit about what might be causing these problems and perhaps a little bit about what we might be able to do about these kind of things in practice. Of course, this isn't a new problem. It's been a thing that we've been wrestling with for quite some time. And for like 10 years before he died, the late Professor Brian Holden and I used to have an ongoing argument about what the causes of this kind of discomfort actually are. Brian was always convinced that it's seated in the cornea, whereas my view was always that it was the eyelids that are the problem. Of course, those of you that know Brian will understand that you argue with Brian at your peril. And Greg Sawyer's information perhaps tends to support Brian's point of view, that in fact it might actually be the cornea that's the seat of all these problems, at least in part. What Greg told us was that the cells on the ocular surface actually really hate being stressed. And when they are stressed, what they do is they put out inflammatory mediators. And these mediators can have a number of effects, perhaps causing the cells to die more quickly than they would otherwise. But also, these inflammatory mediators we perceive in our own eyes as being discomfort or dryness or that kind of a sensation. So this kind of stress to cells is not a good thing. And the kind of things that does cause this stress to happen to cells is, of course, friction, sliding friction, things sliding across the front surface of the cells on the cornea. Now, the thing that slides most of all in the eye, of course, is the eyelid. It blinks 5 seconds or so, every 5 seconds or so, and it moves a long way. So this is a large movement, but it seems that the movement of the eyelid is not so stressful. Why is that? Well, it's because the cornea and the lids expect to encounter one another. So the eyelid expects to see the cornea, and the cornea expects to see the eyelid. So they're very well adapted to one another so that they don't cause stress to their various cells on their surfaces. Think about a contact lens though. A contact lens doesn't move very much, but because its surfaces are not so highly adapted to be what the eye would like to see, even those small movements of the contact lens can actually impart quite a lot of stress to those cells on the ocular surface. So what we're talking about here is friction. So the contact lens seems to be able to transfer more frictional force to the ocular surface than perhaps the eyelid does, even though it doesn't move quite so much. So potentially then, with the contact lens in place, we're giving those corneal cells a little bit of stress, setting off all these inflammatory responses, and arguably beginning that discomfort response as well. So what would be ideal is if we could make our contact lenses look a little bit like the cornea on its front surface, and a little bit like the lid on its back surface. And of course, what intervenes in all this situation, what harmonizes this situation between the lid and the ocular surface, is the tear film. So a good tear film gives us good lubrication and makes this situation one that's acceptable for the eye and for the lids and the cornea. And this brings us nicely to what Jennifer Craig was talking about, because she pointed out to us that the tear film is an extremely important factor in ocular health. Of course, the tear film is very thin. It's probably only 3 or 4 microns in thickness. And when we put a contact lens in that situation, the contact lens is at least 25 times thicker than that tear film. So that's going to cause some change in the situation on the ocular surface. If we're lucky, that contact lens will divide the tear film. So part of it will go behind the lens, part of it will sit on top of the lens, and hopefully that part on top will still behave in a normal fashion. I think though it's a little bit more likely that what actually happens is when we put that lens in place, it disrupts that tear film. And in many cases, the lipid layer, which we hoped would be on top of the contact lens, is at least altered, and in some cases it might be disrupted or abolished altogether. What that means is that we get an increase in evaporation, And we destroy or disturb that very low friction environment that we would have in the absence of a contact lens. What that means, of course, is that we're more likely to get ourselves into the situation where that sliding friction causes problems. So maintaining a happy and healthy tear film is extremely important in making our contact lenses comfortable. Of course, it's also important because if we disturb that good tear film environment, we may actually push our contact lens wearers over the edge into having actually a dry eye problem. Jennifer talked about the vicious cycle of dry eye disease, and we know that we can enter that cycle at any point. So if we stress the tear film a little bit, it's possible that we can push our people into this vicious cycle and precipitate some of the issues of dry eye. And that's on top of the things that Greg Sawyer talked about with relation to the contact lens itself. So as practitioners, we have a responsibility to work towards preserving the tear film to be as healthy and as normal as possible to prevent not only contact lens related problems, but also problems perhaps related to precipitated dry eye. So maintaining the best possible conditions for the interaction between the contact lens and the ocular surface is really critical. And how do we do this? Jennifer talked about some great ways to do this. We need to improve that tear quality as much as possible. And that means managing the health of the eyelids, perhaps to improve the thickness of the lipid layer, and actually promoting the flow of healthy meibum onto the ocular surface. Because we do know from some work that my group did that, in fact, contact lens wear does tend to interfere with the meibomian glands a little bit as well. So we might want to make sure that we treat any potential meibomian gland dysfunction, make sure those lid margins are very healthy and maintain hygiene so that we maintain that natural flow of meibum onto the ocular surface. Of course, part of this that's very important is making sure that our patients and our contact lens wearers actually understand what it is we're trying to do here. If they don't understand what we're trying to do, it's very difficult for them to comply with what we tell them to do and to maintain that compliance. So patient education and continual reinforcement of that situation is very, very important for us. So optimizing the tear film is a key responsibility for us as practitioners. But what about the contact lenses itself? Remember that Greg showed us some beautiful graphs where he was sliding contact lenses across cell layers. And you may remember that some of those lenses behaved better in that respect than others. They caused less damage, less interaction with those cells in the lab than other lenses did. So this suggests to us that perhaps the surface properties of the contact lens can be altered, can be modified to improve their performance. In fact, to minimize this sliding friction interaction that we see with many contact lenses. And actually, Lyndon Jones talked a little bit about how we might potentially achieve this. So the strategic approach that he was alluding to begins with looking at the front surface and the back surface of the lens. Remember, we said ideally we'd like the front surface of the lens to look like the cornea. So if we can make the lens look like the cornea, then we're in a good situation, a good space. So this approach is generally known as biomimicry. And what happens is that we use a number of very clever molecules, all of which have rather complicated names, and the one that Lyndon mentioned is called 2-methacryloxyethyl phosphorylcholine. They've all got horrible names, but they do very interesting things. And this particular molecule, which is usually called MPC for short, helps the contact lens surface, to mimic some of the properties of a natural cornea. So some of the things that it can do is to make that contact lens surface be resistant to deposits. It also tends to resist bacterial adhesion, and it's very wettable, which means that its frictional interaction with the ocular surface is reduced, rather like would happen on the cornea. So lenses using this biomimicry approach are very attractive to us as practitioners. And hopefully these are some of the kind of things that we'll see happening on lenses as we go into the future. Okay, so we've had words of wisdom from our three professors, and what we're going to do now is bring them all back together and have a bit of a roundtable discussion and try and bring a little bit more detail out of some of the things they've said. So just to kick things off, I thought I might just ask Lyndon to give us a bit of a view of really, is discomfort still a big problem in clinical practice?
Yeah, I think it is. I think if you look at the studies that have been published on discomfort, while some of them are fairly old, if we look at some of the dropout studies that have been conducted within the last couple of years, we're still seeing significant numbers of patients dropping out. And when you survey those patients, then the major reason why they drop out is discomfort, particularly at the end of the day. So I still think this issue around discomfort is something that we need to tackle in everyday practice if we're going to keep this retention of patients going for any length of time.
And this isn't just a North American problem, I guess. Jen, you see the same kind of thing down where you are in New Zealand?
Absolutely. I think, and I think it's a problem we have in trying to grow the market is we have a lot of people dropping out. We may be building our practices, but we're losing patients as well to discomfort. I think it matters as well how you ask patients. I think we need to be asking patients carefully what they're experiencing. And but yes, I think a lot of it does come down to discomfort in the end, and it's a major reason for dropout, unfortunately.
Yeah, I know. At BCLA, I think year before last, actually, we actually asked the audience how many of them had patients that experienced discomfort as a problem, and I forget the exact numbers, but it was something like a third of the audience said their patients were significantly affected by discomfort. So it clearly is still an issue for us. So I guess the next question then is really what's causing discomfort, and we've talked about some of those things in the talks before. So Greg, I just thought I might come back to you and ask you, so what's the one thing in your view, based on your work, that you think is at the root of discomfort problems with contact lenses?
Yeah, so I think the whole topic of pathological pain is really complex. So I don't think I can give you an answer of one thing that leads to pathological pain. The one thing that we've discovered is that cytokines and inflammation are powerful signaling proteins that can be triggered in the eye through frictional shear, and those are directly linked to pathological pain and that transduction through those highly innervated tissues, both on the cornea and the underside of the eyelid.
So you're saying that the sliding of the lens against the corneal cells causes those cells to put out these molecules which signal to the nerves on the ocular surface that something's wrong?
Yeah, for sure. And I think it makes sense. We're designed to protect our vision. So we're sliding on cells that are part of the innate immune system, but they're also cells that sense and respond to the environment. And they do that very quickly. So they're essentially programmed to respond to frictional shear. And that is one of their roles to protect our sight.
So given that the biggest thing that I can see that causes frictional shear in the eye is the eyelid, it's like banging across the cornea all the time. So why don't we get that problem all the time? Why is it only a problem in contact lens wear?
Yeah, so I think it's some of the things that Jen and Lyndon both brought up in their talks. One of them is you've taken a biological interface that was a self-mated cell-on-cell interface with a mucinated network that separates those two cells, and you've inserted a synthetic object that's roughly 13, 15, 20 times as thick as the natural tear film. But more important than the thickness is you've now fundamentally altered the pairing from an all biological interface where the cells are soft, wet, slippery, to one of cells on a synthetic surface and then synthetic surface on a cells. So you've altered that natural interface by the insertion of the contact lens, which is why you have to work on those contact lens surfaces to try to get that mimicry back for the other side of the pairing, the cellular side.
So that this sliding interaction's a potential big problem. Is there anything else going on that's leading to these discomfort sensations? Lyndon, Jen, do you have any other suggestions of what might be at fault here?
Well, I mean, certainly from breaking down the tear film, I mean, just from having the lens in position, exactly like Greg said, you got something so huge you're putting into the tear film. It's very disruptive, and that causes a lot of tear film instability, and that instability is going to lead to higher rate of evaporation, which leads to hyperosmolarity, and that's something else that I think is another big trigger as well for the sensations. So I think it's just the bulk of the lens in position and how much that might move around as well and disrupt the tear film, because it's very difficult to keep a lipid layer over the surface of the tear film with a big lens in position.
So I guess what you're saying is that the structure of the tear film on top of the lens is critical. So we need to try and make that as normal as we possibly can. Yeah. So how do we go about doing that? What are the clinical strategies that we can do to, in this case, keep a regular tear film at the top of the lens? What are your thoughts there?
So I think I love Greg's description of, you've basically put this interface in that's completely destroyed all the biology, that beautiful area of cells on the underneath of the lid and on the cornea with this, lovely, beautiful tear film in between acting as a lubricant, and you shove this piece of plastic in there. And I think one of the things that we're beginning to learn is that, for a long time we were trying to develop contact lens materials that actually resisted the tear film. Let's not have deposition. Let's not have any encouragement of the tear film to interact with the lens material at all. And I think we're beginning to realize that doesn't work. We really actually want to develop lens materials that encourage an interaction with the tear film and actually get the good stuff from the tear film to actually be incorporated into the lens. And it's kind of like the biology in the rest of the body whenever you put an implant in. You don't want to resist stuff. You actually want to encourage certain types of proteins to be interfaced on those materials. And I think that's one of the fundamental things that we can do moving forward, is actually develop materials that encourage an interaction with the tear film rather than resist the tear film. And I think that's a way of overcoming that really beautiful description that Greg's just given.
Mm-hmm. I think also recognizing that patients have risk factors with contact lens, where risk factors they would have had anyway, but we're maybe tipping them over the edge with the contact lens. So if they have signs of lid disease and things, we could be making things better. So the more robust we can make the tear film before we start, then the better a chance you have of being able to retain some lipid with the lens in position. If you imagine a lens is going to knock the tear film, the lipid layer down by about 1 grade on average. If you start with a low lipid grade, you end up with no lipid on the surface. If you can start with a reasonable amount of lipid, you've got some chance of retaining that lipid layer over the surface if the lens isn't moving too much.
So from a clinical perspective then, if you're fitting a new person and their meibomian glands don't look too good, you're thinking about pre-treating them before you fit them with the contact lens?
I would.
I think most practitioners don't think, they think about doing a dry eye workup in a dry eye patient. They don't think about the fact that the ocular surface needs to be as pristine as possible in a contact lens patient. And even the best contact lens solution and replacement cycle and solution is not going to work well if you don't have a really good ocular surface. So I think that's a really important part of why we don't address this contact lens discomfort, because the first thing you do is, well, let's change the lens or let's change the solution, as opposed to, I wonder if it might actually be the patient that's the problem. Let's look at addressing their issues and actually leave the lens and solution alone. And I think that's a really, really important point.
It's important, for practitioners to, if they're going to understand the mechanisms involved, they want to see clinical signs that they can recognize. And so we talked about the discomfort sensation being something else. But I think one of the things that you pointed out is that these cytokines may accelerate cell death, apoptosis. So would people see that in terms of the things that are happening on the ocular surface? I mean, will it cause corneal staining, for example?
And I think I have to point that over to Jen and Lyndon. But what we see in trying to understand how the eye manages this environment of sliding 6 football fields a day, the mucin network in the tear film, you should think about it like a mechanical fuse. It's an incredibly fragile dynamic system. So what it does is it gracefully breaks apart during the sliding, okay? And it's that fragility that tries to protect the cells. When you disrupt that with the contact lens, you alter the fragility of the tear film on both surfaces. So what we would expect to see is, for systems that go above kind of a physiological threshold of about 40 pascals of shear stress, you're going to start to see some accumulation of damage in any of those regions where that's concentrated. So that might be on the eyelid, that might be on high pressure spots from fit on the cornea. But, to detect it from staining, you're going to have some concentrated area of that damage to basically detect it.
And so 40 pascals, let's put that into some kind of context. If I rub my eye, how many pascals is that?
Well, when you're rubbing your eye, the tear film is taking care of it for you. So if you close your eyelid and press on it, what happens is you can push about 3 kilopascals, but basically the tear film will break apart constantly to manage it so you don't damage the cornea. Now you put your fingernail in your cornea, you're going to get damage instantly.
So what can we do to that lens to make it a better prospect? What are the kind of things that we can do to make the lens less of a problem for this sliding system?
Yeah, so what we've learned over the years is that basically the lubricity of a lens is a pairing between friction, what the dissipative energy is, and the softness, the modulus. And it's the same trick the body plays. So both of those things are driven by water content in these aqueous gels. So what we work on is driving that water content at that surface to the maximum level. And that's one of the best tricks in essentially polymer physics to try to get back to that biomimic.
Okay, so that's really interesting. But do we think in general that practitioners spend enough time thinking about discomfort and the causes of discomfort, or should they be being a bit more proactive in these areas? Lyndon, what do you think?
I think we don't. I think often what happens is, patient comes in for a progress check. The practitioner will say, how are your lenses feeling? Often the patient will say, oh, fine. Fine is a 4-letter F word. I don't think we should necessarily accept fine. I think we need to seriously, as Jen said, ask about, how comfortable are your lenses? So question them, get them to scale it, on a scale of 0 to 10, what's it like?
Thanks to everyone for those great words. It's been very interesting listening to the three of you talking about the problems that we might have associated with discomfort. And so if I could just sum up a little bit, I think it's important for us to think about discomfort not just as something that happens when we've got somebody sitting in the chair in front of us. But really we need to consider that people might be experiencing discomfort right from the word go, when we first begin to fit them with contact lenses, and think about the things that we can do to combat that problem really right from the beginning. So that way we can think about maybe choosing the best materials, the best wearing strategies, the best care systems to minimize that problem right from the word go. And if we do that, then hopefully we'll have fewer people with problems, and the people that do have problems, it will not be quite so severe. So thanks for joining us today or tonight, wherever you happen to be, and we hope to see you in person soon. Thanks.